Welcome back. Let's dive right in. 1. A 70-year-old male presents with painless hematuria. CT scan shows a 4 cm renal mass. His past medical history includes smoking and hypertension. Which of the following is the most likely diagnosis? A. Polycystic kidney disease. B. Wilms tumor. C. Renal cell carcinoma. D. Transitional cell carcinoma. Answer: C. Renal cell carcinoma. Rationale: Wilms tumor is common in children, not adults. Polycystic kidney disease causes multiple cysts, not solid masses. Transitional cell carcinoma affects renal pelvis/ureter more than renal cortex. RCC is the most common kidney cancer in adults, strongly associated with smoking. Strategy: eliminate age-inappropriate options, Wilms tumor, then link risk factors, smoking, age, and symptom, painless hematuria, to RCC. 2. A patient with renal cell carcinoma develops persistent headaches, dizziness, and visual disturbances. Lab results show elevated hematocrit. Which paraneoplastic syndrome explains this finding? A. Hyperparathyroidism. B. Polycythemia due to erythropoietin production. C. Cushing's syndrome. D. SIAD. Answer: B. Polycythemia due to erythropoietin production. Rationale: RCC can secrete erythropoietin, causing polycythemia. Hyperparathyroidism, hypercalcemia, not polycythemia. Cushing's excess cortisol. SIAD, hyponatremia, not high RBC. Strategy: look for paraneoplastic clues. If RBC in kidney tumor, think erythropoietin. 3. Which diagnostic modality provides the most definitive evaluation for suspected renal cell carcinoma? A. Ultrasonography. B. CT or MRI. C. Urinalysis. D. Intravenous urography. Answer: B. CT or MRI. Rationale: ultrasound can detect mass but cannot characterize it fully. For urography is outdated. Urinalysis may reveal hematuria but is nonspecific. CT/MRI provides definitive imaging to diagnose RCC and assess extent. Strategy: always choose the imaging that provides detail plus staging when cancer diagnosis is suspected. 4. A 68-year-old male with localized RCC, 2.5 centimeters, and poor surgical tolerance asks about alternative therapy. Which is the best option? A. Radical nephrectomy. B. Ablation therapy, radiofrequency or cryoablation. C. Chemotherapy alone. D. Immunotherapy first line. Answer: B. Ablation therapy. Rationale: radical nephrectomy is gold standard for larger/localized tumors, but he is not fit for major surgery. Ablation is recommended for small, less than 3 centimeters, RCC in patients who are poor surgical candidates. RCC is resistant to standard chemotherapy. Immunotherapy is mainly used in advanced/metastatic disease. Strategy: note tumor size plus comorbidity, think nephron sparing or ablation. 5. Which histological feature is most typical of renal cell carcinoma? A. Small round blue cells. B. Clear cytoplasm cells. C. Keratin pearls. D. Reed-Sternberg cells. Answer: B. Clear cytoplasm cells. Rationale: RCC is also called clear cell carcinoma due to glycogen and lipid content. Small round blue cells equals Wilms tumor. Keratin pearls equals squamous cell carcinoma. Reed-Sternberg equals Hodgkin lymphoma. Strategy: no classic pathology buzzwords, RCC clear cytoplasm. 6. Which of the following best describes the prognosis of localized small renal cell carcinoma? A. 5-year survival rate greater than 90%. B. 5-year survival rate 50%. C. Survival rate depends only on patient age. D. Cure is impossible once diagnosed. Answer: A. 5-year survival rate greater than 90%. Rationale: small, confined RCC has excellent prognosis with surgical removal. Prognosis worsens only when spread occurs. Strategy: Recall survival rate data, localized small RCC equals very good prognosis. 7. Which immunotherapy agent blocks the PD-L1 checkpoint pathway in renal cell carcinoma? A. Interleukin 2. B. Interferon alpha 2b. C. Nivolumab. D. Methotrexate. Answer, C. Nivolumab. Rationale. Nivolumab is a checkpoint inhibitor targeting PD-1/PD-L1. IL-2 and IFN-alpha are older immunotherapies. Methotrexate is a chemotherapy drug, not RCC effective. Strategy. Associate modern RCC therapy with checkpoint inhibitors, nivolumab, pembrolizumab. 8. Which risk factor is most strongly associated with renal cell carcinoma? A. High salt intake. B. Smoking. C. Family history of colon cancer. D. Male circumcision. Answer, B. Smoking. Rationale. Smoking doubles RCC risk. Colon cancer family history is unrelated. High salt hypertension, not RCC. Circumcision penile cancer prevention. Strategy. Pick the direct and proven RCC risk factor, smoking. 9. Which metastatic site is most common in renal cell carcinoma? A. Brain. B. Lung. C. Liver. D. Skin. Answer, B. Lung. Rationale. RCC commonly spreads hematogenously to lungs early. Brain/liver can also be affected, but lung is most common. Strategy. Think, kidney direct venous drainage lungs. 10. A patient has undergone nephrectomy for RCC. 2 years later, CT shows lung metastases. Which therapy is most appropriate? A. Standard chemotherapy. B. Hormonal therapy. C. Immunotherapy with checkpoint inhibitors. D. Immediate repeat nephrectomy. Answer, C. Immunotherapy with checkpoint inhibitors. Rationale. Standard chemotherapy is ineffective in RCC. Hormonal therapy has no role. Repeat nephrectomy is not curative when metastasis exists. Immunotherapy, checkpoint inhibitors, is current standard for metastatic RCC. Strategy. When you see metastatic RCC, think immunotherapy/targeted therapy. 11. A 66-year-old man presents with painless hematuria and crampy flank pain. CT shows a mass in the renal pelvis. Which cancer is most likely? A. Renal cell carcinoma. B. Transitional cell carcinoma. C. Squamous cell carcinoma. D. Adenocarcinoma. Answer, B. Transitional cell carcinoma. Rationale. Most renal pelvis and ureter cancers are urothelial, transitional cell carcinoma. RCC originates in renal parenchyma, not pelvis. Squamous and adenocarcinoma are rare. Strategy. Hematuria plus renal pelvis involvement urothelial carcinoma. 12. The best diagnostic procedure to directly visualize and biopsy a suspected ureteral tumor is A. Intravenous urography. B. Ureteroscopy. C. Cystoscopy. D. MRI. Answer, B. Ureteroscopy. Rationale. Ureteroscopy allows direct visualization plus biopsy. For urography is outdated. Cystoscopy is for bladder. MRI is imaging, not tissue confirmation. Strategy. When asked for direct visualization plus biopsy, always pick endoscopic approach. 13. After nephroureterectomy for renal pelvis cancer, which procedure is necessary for long-term monitoring? A. Chest CT every 6 months. B. Cystoscopy indefinitely. C. Colonoscopy every 2 years. D. PET scan annually. Answer, B. Cystoscopy indefinitely. Rationale. Patients with urothelial carcinoma of renal pelvis are at high risk of subsequent bladder cancer. Hence, indefinite cystoscopy is essential. Strategy. Remember, upper tract urothelial cancer monitor bladder lifelong. 14. Prognosis of renal pelvis cancer is poorest when A. The tumor is confined to the mucosa. B. The tumor spreads into the wall of ureter/pelvis. C. Patient is older than 60. D. Chemotherapy is given post-surgery. Answer: B. The tumor spreads into the wall. Rationale: invasion into wall or distant sites drastically reduces survival. Age alone is not determinant. Post-op chemo may improve outcome, not worsen it. Strategy: think, depth of invasion equals prognosis in urothelial cancers. 15. Which cell type accounts for most bladder cancers? A. Squamous cell. B. Adenocarcinoma. C. Transitional, urothelial, cell. D. Small cell. Answer: C. Transitional, urothelial, cell. Rationale: majority are urothelial, transitional cell. Squamous and adenocarcinoma are rare. Strategy: always default to transitional cell for bladder cancer unless specified otherwise. 16. The strongest single risk factor for bladder cancer is A. Schistosomiasis. B. Smoking. C. Chronic catheter use. D. Cyclophosphamide therapy. Answer: B. Smoking. Rationale: smoking causes 50% of bladder cancers. Schistosomiasis squamous bladder cancer, in endemic regions. Catheter/chronic irritation are minor risk factors. Strategy: think smoking first for bladder cancer risk. 17. Which occupational exposure is classically linked to bladder cancer? A. Lead. B. Asbestos. C. Aniline dyes. D. Silica. Answer: C. Aniline dyes. Rationale: dye industry chemicals, naphthylamine, aniline, equals classic bladder cancer risk. Strategy: bladder equals dye industry memory hook. 18. A patient with bladder cancer undergoes cystoscopy and biopsy. The tumor is confined to mucosa. What is the best treatment? A. Total cystectomy. B. Intravesical immunotherapy, BCG. C. Radiation therapy. D. Chemotherapy only. Answer: B. Intravesical immunotherapy, BCG. Rationale: superficial bladder cancer equals TURBT plus intravesical BCG/chemo. Radical cystectomy reserved for invasive disease. Strategy: confined to mucosa equals treat with intravesical therapy. 19. A 72-year-old man with invasive bladder cancer is planned for cystectomy. Which postoperative urinary diversion allows him to void through the urethra naturally? A. Ileal conduit. B. Orthotopic neobladder. C. Indiana pouch. D. Suprapubic catheter. Answer: B. Orthotopic neobladder. Rationale: neobladder connects reservoir to urethra, allowing near-normal voiding. Ileal conduit stoma with external bag. Indiana pouch catheterized stoma. Strategy: natural voiding equals orthotopic neobladder. 20. A patient underwent total cystectomy with ileal conduit. Which complication is most likely? A. Erectile dysfunction. B. External urine collection bag dependence. C. Risk of recurrent bladder cancer. D. Hyperkalemia due to urine absorption. Answer: B. External urine collection bag dependence. Rationale: ileal conduit diverts urine to stoma bag required. Erectile dysfunction is more linked with prostate surgery. No recurrent bladder cancer if bladder is fully removed. Strategy: ileal conduit equals external bag. 21. Which imaging test is most useful in staging bladder cancer locally, extent of invasion? A. Ultrasonography. B. CT abdomen. C. MRI pelvis. D. PET scan. Answer: C. MRI pelvis. Rationale: MRI is best for local staging, depth of invasion. CT evaluates spread. US not sufficient. PET less useful initially. Strategy: MRI equals local staging, CT equals spread. 22. What is the 5-year mortality rate for superficial bladder tumors? A. Less than 5%. B. 20%. C. 50%. D. Greater than 70%. Answer: A. Less than 5%. Rationale: superficial, non-muscle invasive, bladder cancers rarely kill. Strategy: superficial equals excellent prognosis. 23. What is the 5-year mortality rate for muscle-invasive bladder tumors? A. Less than 10%. B. 20%. C. 50%. D. Greater than 80%. Answer: C. 50%. Rationale: muscle-invasive bladder cancer carries 50% death rate at 5 years. Strategy: muscle invasion equals major prognostic divider. 24. In bladder cancer, intravesical BCG works by A. Directly killing tumor cells. B. Stimulating immune response in bladder wall. C. Blocking androgen receptors. D. Inhibiting DNA synthesis. Answer: B. Stimulating immune response. Rationale: BCG equals immunotherapy activates immune system inside bladder. Not chemo, not hormone therapy. Strategy: BCG equals immune activation. 25. Which drug is commonly instilled intravesically after TURBT to prevent recurrence? A. Gemcitabine. B. Tamoxifen. C. Cyclophosphamide. D. Methotrexate. Answer: A. Gemcitabine. Rationale: gemcitabine, docetaxel, mitomycin C are used intravesically. Strategy: memorize, gemcitabine docetaxel mitomycin C equals bladder installation. 26. A patient with muscle-invasive bladder cancer refuses cystectomy. Which alternative is acceptable? A. BCG installation alone. B. Radiation plus or minus chemotherapy. C. Observation only. D. Hormonal therapy. Answer: B. Radiation plus or minus chemotherapy. Rationale: radiation plus or minus chemo can be curative in selected patients refusing surgery. BCG only for superficial. Hormonal therapy not used. Strategy: refuses cystectomy? Chemo plus radiation option. 27. Which urinary diversion requires intermittent self-catheterization? A. Ileal conduit. B. Orthotopic neobladder. C. Indiana pouch. D. Suprapubic catheter. Answer: C. Indiana pouch. Rationale: Indiana pouch equals continent diversion catheterization through stoma. Ileal conduit equals external bag. Neobladder equals urethral voiding. Strategy: Indiana pouch equals catheter through stoma. 28. Which bladder cancer subtype is linked to chronic schistosomiasis? A. Transitional cell carcinoma. B. Squamous cell carcinoma. C. Adenocarcinoma. D. Sarcoma. Answer: B. Squamous cell carcinoma. Rationale: schistosomiasis predisposes to squamous bladder cancer. Strategy: endemic area squamous bladder cancer. 29. A patient treated with cyclophosphamide for lymphoma develops hematuria years later. Which complication is most likely? A. Renal cell carcinoma. B. Bladder cancer. C. Prostate cancer. D. Testicular cancer. Answer: B. Bladder cancer. Rationale: cyclophosphamide metabolite, acrolein, damages bladder cancer risk. Strategy: cyclophosphamide equals bladder cancer. 30. Which factor best predicts recurrence risk in bladder cancer? A. Patient age. B. Tumor grade and stage. C. Smoking history. D. Gender. Answer: B. Tumor grade and stage. Rationale: recurrence risk correlates most strongly with grade plus stage. Strategy: for prognosis, always think stage plus grade first. 31. Penile cancer most commonly arises at which anatomical site? A. Urethral meatus. B. Glans penis. C. Shaft of penis. D. Dorsal vein of penis. Answer, B. Glans penis. Rationale. Most penile cancers occur at the glans, especially its base. Less common on shaft. Strategy. Think glans equals hot spot for penile carcinoma. 32. Which histological type accounts for most penile cancers? A. Squamous cell carcinoma. B. Adenocarcinoma. C. Basal cell carcinoma. D. Melanoma. Answer, A. Squamous cell carcinoma. Rationale. Squamous cell carcinoma is the predominant penile cancer. Strategy. If asked histology, always squamous cell. 33. Which of the following is the strongest protective factor against penile cancer? A. Regular condom use. B. Childhood circumcision. C. HPV vaccination in adulthood. D. Daily hygiene with antiseptic wash. Answer, B. Childhood circumcision. Rationale. Early circumcision nearly eliminates penile cancer risk. HPV vaccination helps but not as strongly as circumcision. Strategy. Circumcision equals prevention. 34. The most important infectious risk factor for penile cancer is A. HSV2. B. HIV. C. HPV, especially type 16. D. EBV. Answer, C. HPV, type 16. Rationale. High-risk HPV, 16, 18, strongly linked to penile squamous carcinoma. Strategy. Penile cancer HPV. 35. A man presents with a reddish velvety lesion on the glans. Biopsy shows carcinoma in situ. This is most consistent with A. Erythroplasia of Queyrat. B. Bowen's disease. C. Balanitis. D. Melanoma. Answer, A. Erythroplasia of Queyrat. Rationale. Erythroplasia of Queyrat equals CIS on glans. Bowen's disease equals shaft/prepuce CIS. Strategy. Red velvety lesion on glans, erythroplasia of Queyrat. 36. Which treatment is best for early small penile squamous carcinoma in situ? A. Topical imiquimod. B. Total penectomy. C. Chemotherapy. D. External beam radiation. Answer, A. Topical imiquimod. Rationale. Small/early lesions, topical 5-FU or imiquimod, or laser excision. Radical surgery reserved for advanced. Strategy. Match lesion size with least mutilating treatment. 37. Lymph node involvement in penile cancer first occurs in which nodes? A. Paraortic. B. Pelvic. C. Inguinal. D. Iliac. Answer, C. Inguinal. Rationale. Lymphatic drainage of penis inguinal nodes first. Strategy. Penis inguinal. 38. Which prognostic factor has the greatest impact on survival in penile cancer? A. Tumor size. B. Lymph node involvement. C. Patient age. D. Circumcision status. Answer, B. Lymph node involvement. Rationale. Node metastasis dramatically worsens prognosis. Strategy. Always pick node involvement as prognostic factor. 39. Which is the best prevention strategy for penile cancer globally? A. HPV vaccination of adolescents. B. Mass screening with biopsy. C. Regular antibiotics for balanitis. D. Prophylactic chemotherapy. Answer, A. HPV vaccination. Rationale. HPV vaccination in boys prevents HPV-driven cancers. Screening/chemo not practical. Strategy. Global prevention HPV vaccine. 40. 5-year survival is poorest in penile cancer patients with A. Lesions limited to glands. B. Lesions excised with laser. C. Spread beyond groin lymph nodes. D. Treated with topical imiquimod. Answer, C. Spread beyond groin lymph nodes. Rationale. Once beyond groin nodes, prognosis worsens drastically. Strategy. Node spread equals poor survival. 41. Which is the most common cancer among men in the United States? A. Lung cancer. B. Colon cancer. C. Prostate cancer. D. Pancreatic cancer. Answer: C. Prostate cancer. Rationale: prostate cancer equals most common, excluding skin cancers. Strategy: always remember, prostate equals number 1 in men. 42. Which demographic group has the highest risk of prostate cancer? A. White men, Europe. B. Black men, Caribbean. C. Asian men, East Asia. D. Hispanic men, South America. Answer: B. Black men, Caribbean. Rationale: incidence highest in black men, especially Caribbean origin. Strategy: risk equals black ethnicity. 43. Which symptom is least likely in early prostate cancer? A. Nocturia. B. Weak urinary stream. C. Hematuria. D. Bone pain. Answer: D. Bone pain. Rationale: bone pain equals late metastatic symptom. Strategy: ask, early versus late bone pain equals late. 44. Which initial screening test is most widely used for prostate cancer? A. Serum alkaline phosphatase. B. Serum PSA. C. MRI pelvis. D. Prostate biopsy. Answer: B. Serum PSA. Rationale: PSA widely used for screening. Biopsy is diagnostic, not screening. Strategy: screening equals PSA plus DRE. 45. Which Gleason grade group corresponds to Gleason score 7, 4+3? A. Group 1. B. Group 2. C. Group 3. D. Group 4. Answer: C. Group 3. Rationale: 7, 3 plus 4 equals Group 2. 7, 4 plus 3 equals Group 3. Strategy: memorize, 3 plus 4 is equal to 2, 4 plus 3 is equal to 3. 46. A 58-year-old with low-risk prostate cancer, PSA less than 10, grade Group 2, confined tumor. Best management? A. Radical prostatectomy. B. Active surveillance. C. Chemotherapy. D. Radiation therapy only. Answer: B. Active surveillance. Rationale: low risk plus confined surveillance reasonable. Strategy: low risk avoid overtreatment. 47. In prostate cancer, which site is most common for metastasis? A. Lung. B. Liver. C. Bone, pelvis, ribs, vertebrae. D. Brain. Answer: C. Bone. Rationale: bone metastasis, pelvis, vertebrae, equals most common, painful. Strategy: prostate cancer bone first. 48. Which staging modality is best to detect bone metastasis in prostate cancer? A. Bone scan, nuclear medicine. B. MRI brain. C. CT abdomen. D. PET with FDG. Answer: A. Bone scan. Rationale: nuclear bone scan equals standard for bone mets. Strategy: bone scan. 49. Which surgical treatment is potentially curative for localized prostate cancer? A. TURP. B. Radical prostatectomy. C. Bilateral orchiectomy. D. Cryotherapy. Answer: B. Radical prostatectomy. Rationale: only radical prostatectomy or radiation are curative for localized disease. Strategy: localized equals radical prostatectomy. 50. Which complication is most likely after radical prostatectomy? A. Hypertension. B. Erectile dysfunction. C. Pulmonary embolism. D. Gynecomastia. Answer: B. Erectile dysfunction. Rationale: nerves for erection cross prostate may be damaged. Strategy: prostatectomy ED plus incontinence. 51. Which radiation therapy method involves permanent radioactive seed implants in prostate? A. External beam radiation. B. Proton beam therapy. C. Brachytherapy. D. Radium-223. Answer: C. Brachytherapy. Rationale: brachytherapy equals seed implants. Strategy: seeds equals brachytherapy. 52. Which prostate cancer treatment works by blocking testosterone production at the pituitary/testis level? A. Orchiectomy. B. LHRH agonists, luprolide, goserelin. C. Antiandrogens, flutamide. D. Finasteride. Answer: B. LHRH agonists. Rationale: LHRH agonists suppress LH testosterone. Strategy: hormonal therapy, LHRH or orchiectomy. 53. Which is not a side effect of androgen deprivation therapy? A. Hot flashes. B. Osteoporosis. C. Increased libido. D. Gynecomastia. Answer: C. Increased libido. Rationale: ADT reduces libido, not increases. Strategy: always expect testosterone effects. 54. Castrate-resistant prostate cancer, CRPC, is defined as A. PSA rise despite low testosterone. B. Metastasis to bone only. C. Resistance to radiation. D. Cancer recurrence after orchiectomy. Answer: A. PSA rise despite low testosterone. Rationale: CRPC equals cancer progressing even when testosterone suppressed. Strategy: CRPC equals disease progression despite castration levels. 55. Which novel agent is a vaccine targeting prostate cancer cells? A. Sipusel. B. Enzalutamide. C. Abiraterone. D. Docetaxel. Answer: A. Sipusel. Rationale: Sipusel equals autologous dendritic cell vaccine. Strategy: only cancer vaccine approved in prostate cancer. 56. Which drug blocks androgen receptor signaling directly? A. Abiraterone. B. Enzalutamide. C. Luprolide. D. Radium-223. Answer: B. Enzalutamide. Rationale: enzalutamide equals AR antagonist. Abiraterone blocks androgen synthesis. Strategy: no mechanism differences, AR blocker versus androgen synthesis inhibitor. 57. Which drug is used specifically for prostate cancer bone metastasis, emitting alpha radiation? A. Radium-223. B. Strontium-90. C. Cisplatin. D. Mitomycin. Answer: A. Radium-223. Rationale: Radium-223 targets bone mets, improves survival. Strategy: bone mets radium-223. 58. Which supportive medication helps strengthen bones in men on ADT? A. Alendronate. B. Zoledronic acid. C. Prednisone. D. Aspirin. Answer: B. Zoledronic acid. Rationale: zoledronic acid plus denosumab prevent osteoporosis/fractures. Strategy: ADT bone loss bisphosphonate or denosumab. 59. Which prostate cancer screening recommendation is currently most accepted in the U.S.? A. All men greater than 40 yearly. B. Men 55 to 69 discuss PSA testing with doctor. C. Only men with symptoms. D. All men greater than 70 annually. Answer: B. Men 55 to 69 discuss PSA. Rationale: USPSTF, shared decision-making for ages 55 to 69. Strategy: remember 55 to 69 equals PSA discussion. 60. Prognosis of metastatic prostate cancer is typically A. Curable in most cases. B. Median survival 1 to 3 years. C. Median survival 5 to 10 years. D. Same as localized disease. Answer: B. Median survival 1 to 3 years. Rationale: no cure for metastatic disease, survival usually 1 to 3 years. Strategy: Localized versus metastatic drastic survival difference. Great job making it to the end of this session. By practicing these tough MCQs with rationales and strategies, you've built the confidence to tackle even the hardest exam questions on genitourinary cancers. If you found this video helpful, don't forget to like, subscribe, and share it with your classmates. And hit that notification bell so you never miss our next set of high-yield questions. Thanks for watching, keep practicing, and I'll see you in the next video. Good luck with your exams.